it's always a challenge, but I like a challenge. And I feel like this healthcare system is just that. It's the biggest challenge that we face as a nation. And it really needs to, we need to find some solutions, right? And I know that's what you and your company are trying to do as well. So it's about being partnered with other people like you know, in your company who are trying to make a difference. And that's what I love about the space that I'm in right now.
Hello, everyone. Welcome back for another episode of our Healthy Savings podcast. I'm Sasha Gribov. I'm your host. I'm the co-founder of a company called Milu. And today we're joined by Liz Antaya, who's an employee benefits advisor with Stahl and Associates. And Liz, we're so excited to have you on the pod.
I'm so excited to be here. Thank you so much, Sasha. I really appreciate the invitation.
Absolutely. So we love starting off just by getting to know you. Who are you? How did you get here? Where do you work? And why do you do what you do?
That's a loaded question. So yeah, no, it did take me some time to get here. I learned in this life to never say never. I grew up with my mom owning an Allstate agency, and I said I'd never do anything having to do with insurance, and didn't think I'd be back in Lakeland, Florida either. But that's where I am, in Lakeland, Florida, doing insurance. I've been doing this for almost 14 years, and I've been with Stahl and Associates for going on 10 now. Crazy how time flies. Just as an aside, Stahl and Associates Insurance was the largest privately held insurance agency in the state of Florida. But just last summer, just like everybody else, we got acquired by a much larger company called Higginbotham. So we're excited about that. New partnership means new resources and opportunities. So we're learning more about what that means every day. But in my kind of endeavor to learn more about healthcare, I wanted to learn more about, I was just doing BUCA plans when I started, just like everybody else for small, mid groups. But I really wanted to get in the self-funding arena where I really felt I could make a bigger difference. But it was hard to find people, other benefit advisors who weren't running around with their heads on fire. So I ended up joining a cohort of people headed by Tom Scott, who did my master's degree in health benefit design. So I signed up for that out of the University of Lynchburg. And I'm so glad I did, because it wasn't just the content and all that I learned, because I learned a ton, but it was the people that I met and the influencers in this industry that I became acquainted with. And it was through that program that I became familiar with the Health Rosetta movement and Dave Chase and so many other industry leaders. And that's why I joined Health Rosetta and that movement, and later Mitigate Partners and Carl Schuessler. So that has been a real game changer for me, because I want to be able to make a difference, right? And you just can't do it in that BUCA world.
It's really cool that you went back to get a higher degree in this specific field. Most people don't. What was that process like? Like what did you start seeing that made you say, hey, I want to figure out self-funding and like I need to go deeper and understand this stuff?
So to me, it is and can be a complex industry, right? In the self-funding world, in the fully insured, not so much. We call it pushing the easy button, right? But you just get so little in return. You just pay out and you get very little care. And just incidentally, I'm a product of, my father was a 40-year practicing physician here in town. So I kind of know it from that provider perspective. And I wish he were still alive, because I'd love to have some conversations. Unfortunately, he passed away in 2012, and he was a psychiatrist. And there's a huge need for that specialty these days. You know, with, like I said, with regards to self-funding, that's the only place you can really make a true difference. But it's nice that smaller employers, now we can get into that, are able to jump into that, because I think it's only been reserved for the large and mega employers in the past. But I just felt like I had to know the intricacies, and there were so many of them. And taking that master's degree class, it was kind of revealed to me. I remember one class where all like, why are we looking at doing this? It was the FIA group taught by some of the attorneys, right, at the FIA group. And it kind of scared us. It was like, oh my goodness, there's so many things to be aware of. But you know, as an advisor, I have to be aware of all of them.
You've got to, I mean, it's a hard space. You have to be the expert. You are the trusted resource that an employer, the employer is not the expert in self-funding unless, I don't know, you're Walmart and you've got, hundreds of people working on it. But otherwise, like, they go to you and you gotta answer a lot of different questions for them.
Right, right. And if I'm not the expert, I have to know who to go to. And so that, like, I can't be like, I have people who do PNC, do benefits, do like, you can't be a master of all. And I wanted to specialize and focus on this space because there's so much within it, right? Like, and as soon as you know all the answers, they change the questions, by implementing a new law or regulation, CAA, as we know. I started in 2010, which was kind of a funny time to go in employee health benefits space with the Obamacare had just come out. So it's always a challenge, but I like a challenge. And I feel like this healthcare system is just that. It's the biggest challenge that we face as a nation. And it really needs to, we need to find some solutions, right? And I know that's what you and your company are trying to do as well. So it's about being partnered with other people like you, in your company who are trying to make a difference. And that's what I love about the space that I'm in right now.
Yeah, same here. I mean, it's not static. Like, things are changing, and there's a lot of people pounding the table saying, we think this can be different. Whether those are doctors who are saying, what I'm doing right now is unsustainable. I can't be putting in 12-hour days and putting in another 2 hours at home typing in stuff onto my medical record, and then billing's messed up regardless, to employers, to patients. Like, it doesn't work for anyone right now.
Right. Yeah. And again, with regards to the doctors, it's kind of nice seeing that wave of doctors who are not happy with the way the system is going. Right. And so the DPC move, I'm surprised there aren't more doctors that are moving to that model, just because I think that's why they got in the space that they did, to do no harm, to care for patients, and to really be able to establish that relationship. I just went, I do have a DPC, but I also still have the conventional PCP. And I just went 2 weeks ago. And I'm always I'm like, because I want to experience it myself, right? What the typical American is experiencing. And it's so true. You wait a couple of weeks to months to get in, to have that 7 minutes, wonderful 7 minutes with your provider once a year. How can they know you? How can they know your goals? They can't. I mean, the bottom line is they can't.
I had the exact same thing. I mean, we moved. I needed a new primary care physician. Saw someone. They were fine, but then to schedule an appointment, it was literally scheduling 12 months out. And I was like, that's great for a checkup, but like, what if something's wrong? And so I went to someone else. And scheduling still longer, but they're incredibly responsive. And they're not a DPC. They're still a traditional primary care, but just having a relationship with a doctor who's able to be a little bit more responsive and there and like answering messages and engaged, it's huge. We had the same thing with our pediatrician for my 6-year-old. Some stuff going on, and she's like, here's my email address, just like email me. And like, that's not sustainable for a typical doctor, right? Like, they don't have time, they don't get paid for it. So if you have models where they can, and it can be sustainable, it's a game changer.
Right. And there are models like that now, right? So it's not fee for service, and I don't think that's the route to go. But I just love the groups of mine that the employers, we call them courageous employers, right? Because they have to be a little bit to buck this system that they're in. Most of them have been locked in for years. When they see the value of removing the middleman and going direct. We always like to say, like, the Marcus Welby days for those who are old enough to remember him. And we have that one visual I know you've seen where the doctor's looking through another person to see in the ear of, I mean, it just makes no sense. You've got to remove the middles and go back to what it should be, what it used to be, going direct, like the direct primary care relationship. And that would be my vision. That would be my hope for everybody in America to have that experience, have that opportunity. One of my favorite kind of jokes is 65% of all statistics are made up on the spot.
I love that one.
But I truly have read that, I mean, DPC doctors should be able to take care of 75 to 85% of a person's medical needs, right? I mean, that's huge.
It's crazy. Like, if you at Milu, we like dreaming up big stuff and then bringing it down to the world of reality. But like, let's dream big. Like your point on every American should have a direct primary care doctor who they could get in touch with. It's not traditional fee for service that's just there. Like that wouldn't actually break the bank if you think about the cost. I haven't looked at these numbers, but like what's the average cost for an employee on a traditional plan? It's what, 14 grand, 15 grand, something like that. Maybe a family is like 20
a
grand.
year. Mm-hmm.
Yeah. Like what's a DPC cost per employee? $100 a year, maybe?
$100 a month. So it could be 60 to $100 a month, but still do the math.
Yeah.
Right?
Like that's a tiny, tiny fraction. Now, I also get it if you layer it on top of a traditional plan, it's hard, it's a new cost. But if you're reducing costs somewhere else and you're providing the service, it's such a game changer for people. You mentioned self-funding before and kind of moving into the world of learning about it and starting to think about it and then implementing it with your clients. And one thing we haven't talked about, at least on this podcast yet, has been smaller groups going self-funded. Have things changed either in the country or in Florida? Is it state by state? Like, how do you think about self-funding for groups that you talk to? Who's a good candidate? Who's a bad candidate? Who should think about it in the future?
Yeah. So that's a great question. I think things have changed because as I started out saying, I think self-funding had been reserved for the larger groups in the past, but now anybody is a candidate for self-funding. There's so many new companies out there all the time. And it can take a lot of time as an advisor taking appointments. Like people are calling us all the time to be able to learn more about their health plan that's going to fix the system. That's why it's nice to be a part of larger groups like Health Rosetta, like Mitigate Partners who have vetting components, right? Because that can take a lot of time. But I think we as advisors are always looking for that silver bullet too. Like, oh, is there this perfect health plan where they put all the different partners and players together and they all work together so nicely and seamlessly. And there are some of those, I think, but they're always changing and evolving, like you said. But it's really depending on the group size, but under 50 even, it's always been traditionally over 100, right, for self-funding. But even in that 50 to 100 space, and even lower, I've had some companies as low as 5 employees, some 10, some 15. So that's why you have to have it all laid out so we'll go. But that's a level funded option, right? It's just another financial mechanism to be able to bring it to the lower groups. They're paying to the max, but they're dividing that over 12 payments. So it looks and feels like a fully insured model, but you still have some of the flexibility of a self-funded model. You also have the visibility, right, to be able to see the data in the self-funded model. So that's what's really nice. So, and Florida is made up of, especially Central Florida where I am here, and I think really all of America, right, is made up of small employer groups. And they're hurting too. They're feeling the pain of these, every year, these increases to their health premiums. 10, 20, 30, I've seen as high as 65%. It's just insane. It's unsustainable. So they have to look to do something different. And the level funding plans are an option for them.
What's usually the flip between level funded to like self-funded, but not doing level funding? Is it a size usually?
So it could be a number of factors. Usually size is definitely a component. Like I said, over 100, oftentimes we look to go true self-funded. It also can be a product of the employer's cash flow or their, risk tolerance. Because when you're true self-funded, like the clients get usually a weekly email. This is what we're taking out based on your claims this week. It can be a big difference and variability between that. And sometimes we're like, holding our breath before we open the email. We've got great cost mitigation programs in place. So we know it's not going to be too bad, but it can be a big variance. So sometimes it's just a matter of cash flow, right? If they want that cash flow to be even, then a level funded product would most likely be a better option for them.
Got it. That makes sense. Do you still see folks that are scared of self-funding because they don't really understand the reinsurance and stop-loss world? And they're like, what do you mean self-funding? I can't do a $2 million claim.
It's so crazy to me. Oh my goodness, Sasha. My husband is actually a part of an organization here in town. He's an employee and they're over 1,000 employees and are fully insured. because they say just that. And I'm just like, it drives me nuts. He thinks it's too risky and they have a, high cost claimant. And I'm like, well, clearly they don't understand what self-funding is, because most of these groups, like you said, unless they're mega employers like a Walmart, are not true self-funded. They have stop loss, they have risk mitigation in place. So it's really not as risky as employers think. And if they do believe that, I think they don't truly understand the self-funding model. That's our job, right? To help them to understand that.
It's funny. There's a company I know pretty well that's also in the thousands of employees, also fully insured. And like when I was just getting started in this world, I was talking to them about it, and they're like, we looked at the numbers and we've got some high cost claimants, and so like our loss ratio was in the red, and like it wouldn't make sense to move self-funded. And now that I kind of know what I know, or if they were working with an advisor who wanted to dig in a little bit, if you look at that data, I bet I could tell a very different story depending on how you slice it. Like I can't imagine that they wouldn't benefit from going self-funded with the right stop loss decisions.
Right, absolutely. And there are some situations that can get a little bit tricky. I mean, you hear of hemophiliacs, and there's some drugs out there that are just insane that some members need. But there are other mechanisms that you can look to as well, and other partners that can help mitigate those costs. There are answers. You just have to know where to look.
That makes sense. So who are your typical clients? Like who do you work with today? What do they typically come to you with? What are their challenges, and what are they hoping to accomplish?
I like working with car dealers. That's one of my best and brightest accounts. I just love them to death because they were my first employer group that was bold enough to kind of take this jump. And because of it, I will say they got a lot of notoriety. They were on ABC Action News. There was like over a 5-minute segment on them. They are in a national publication of automotive news. They are in our local paper. So because it's
good notoriety.
Yeah. Oh, yeah. I mean, they're like, they have what they call a dealership doctor, a doctor, MD, coming on site to see the employees that sign up for his service. So great notoriety. Are you kidding? Like, who gets this? So I think car dealers, they have a lot of pain, but to be honest, Sasha, it's everywhere. I'll help any employer group who has employees, over 50, they have to offer health insurance. But every employer here is looking to mitigate cost, while hopefully, if they care about their employees, while providing a better healthcare experience for less money for them too. Inflation is just really hurting employee groups here. And so if we can help them in the medical side, I mean, it's just crazy. One of my best friends is going through her second round of fighting cancer. She just started chemo again 2 weeks ago and has already done a GoFundMe page. The majority of GoFundMe accounts are because of medical bills. She has insurance. She has health insurance. To me, it's just insane. It makes no sense at all. Like,
that's crazy.
How can we have a country where people have to raise money for healthcare bills when they're actually insured, right? So if there's any way that we can help mitigate that for the employees, and we do that with a lot of our plans, we put in components so that if they take advantage of them, of course, direct primary care is no cost to them. The employer's paying that 100%. Care navigation too. If they reach out to our care navigators, our nurse navigators, and take their advice, their deductibles can be waived, their out-of-pocket costs can be waived. So a surgery could cost them nothing, because we know if we get them to the highest quality care, it's going to cost them and the plan a lot less money. So and that can make a big difference to the financial situation of our employees. Some are making $17 an hour, right? And so we want to remove those barriers to care as much as possible so they're getting the care that they need.
That's huge. I mean, I didn't know that the majority GoFundMe's were for medical expenses. That's insane. We're working on a case right now, and we just heard today that it should work out really well. It's a person who makes $30,000 a year. They had a $19,000 bill. So step one of that was seeing what was wrong with the bill. There was $4,000 on there that was just incorrectly coded. So now it's $15,000 bill. She still has a $15,000 bill. So we're going through the 501(r) financial aid. It should go to zero, which will be amazing. But like, how is somebody at that making $30K supposed to pay $15K? Like,
They can't.
They can't. It's crazy.
They can't. Or they'll pay $50 a month for the rest of their life. I mean, it's just insane. And like you said, to your point about medical billing errors, I've read, 99% of invoices have medical billing error. I mean, like, so it's insane. You've got to have the mechanisms in place to catch that. You can't just auto adjudicate everything and think it's going to be all right. It's most likely not.
Tell me more about the car dealership that you started out with. Like, they had to be the only car dealership in the state that had a doctor come in and see people, right? Like,
as far as I know, yes, absolutely. And I've talked to several other car dealerships in the area because we've got a network of direct primary care doctors that could do that. Now, when you start getting spread out, because they're all in one location, so granted, it makes it a lot easier to have that doctor on site experience, right? So when you get to the much larger groups that are spread out all over, it's a little more tricky, but it certainly can be done. And we're building out that DPC network as much as we can and as much as is needed. Because like I said, there's a huge component of doctors who are tired of the status quo and the fee-for-service world and want to go back to the traditional way of caring for their patients. So yeah, I mean, I just love this dealership. We actually got an award last year through Health Rosetta called the Rosie Award. So
congrats.
I'm just excited. And we got a new banner I'm going to take over to them. And I hope they display it proudly because they deserve it.
That's awesome. But it's such a huge thing for an employer too. Like, it shows that they're taking care of their people. Yeah. They care enough to invest, because even if they're saving money, they're investing some time. They're doing something different, and it's a big deal. How much did they save by starting to work with you? And
every year they've saved over $200,000 because, again, you set in the stop loss sets. This is your max claim. This is your max claims. Say, 1.2 is what it was when we started, because we did the Buca dance for a number of years. I've had them 9 years now. So they were Florida Blue a number of years, and then they got to a 20% increase. We switched to Humana. They had a huge increase. I mean, they do, to be honest, Central Florida here has a sick population. We have a lot of overweight and obese individuals, which leads to diabetes and so many other comorbidities. So they are struggling with that. So, and then we ultimately went to Cigna level funded in the hopes of getting some more data. And that was just, he just had enough. We got a huge renewal for the first thing, so we wanted to get off that hamster wheel. The owner of the company wanted to get off that hamster wheel. And so our renewals is now are not that, hair pulling, hand wrenching experience, because we've got the claims under control. But every year we're saving several $100,000 because we're keeping them. Here's the max. Here's the expected. We're way under expected claims because of the care navigation system, because of direct primary care, all of the different components we have as part of the health plan.
That's awesome. Is reference-based pricing a part of that one specifically?
We have a custom design network, but it's a wrap with RBP. So if anyone goes outside a network, then RBP comes into play.
Makes sense. Awesome. Where do you think this is all gonna go? Like, for your typical employer like that, let's call it a car dealer in Central Florida, or a manufacturer, or a warehousing company or something like that has a few hundred employees, or even 75 employees. Like, 5 or 10 years from now, as they're thinking about health insurance for their employees, what do you think the options are going to be? Like, what do you want the conversation to be?
I think more and more they're going to be open to this conversation of doing something different, because it's been a little bit of a struggle, because I thought as soon as, we rolled this out and we've seen successes, then I thought, gosh, they're going to be pounding down our door, right? They're going to be lining up to sign up for this. And it's not really the case, just because people are so ingrained. We call it Stockholm syndrome, right? They're just so wed to their captors, and they don't know anything differently. But I think the word's getting out there. I think as prices continue to increase, people are going to be looking under every stone. Hopefully, they're going to be more willing to speak to advisors like myself and companies like yours that are trying to fix the system, right, as best we can. Now, we never say it's perfect, right? And it's, like we said, always evolving. These partners are always evolving. The good thing is that it's plug and play, right? We have the ability to take out one partner and add in another best in class, whereas you're not able to do that in the traditional carrier world. So I think they're going to be more open to having this conversation. At least I certainly hope so. And that they're not just throwing up their hands and thinking, this is all we have to choose from. It's my job to get out there and to help them, at least in my vicinity world, to let them know there is another way. There's a better option. And again, the ultimate goal is to get better quality care to your employees. And if you truly, like you said, if you truly care about them, you're going to want that for your employees, not just for attracting and retaining good employees, because that's a huge struggle here too. But this can certainly help with that when they see that you truly do care for them.
From an employee's perspective, even bringing it back to someone like your friend who's dealing with cancer and has to do a GoFundMe, in your perfect world, if you have an employer who says, okay, Liz, I'm in, like, let's go. I've had enough increases. Like, you guide me and let's set something up that's really going to make a difference. What does that perfect world look like for the employee? Who do they call? What do they see? Who do they talk to?
Yeah.
What are their fears? What are they happy about?
Yeah, so that's a great question, because what we try to do is make it really simple for the employee. In Mitigate Partners, we have a plan, Fair Cost Health Plan, and there's a lot of components. We call it like equate it to building a house, right? You start as the foundation. We'd like that foundation to be DPC, if at all possible, direct primary care. And then we build the plan brick by brick, depending on the demographics and the needs of the group based on analytics, right? Based on data. So if they have a large group of diabetics or cancer in the group, we're going to know to plug in that brick. But so you have all these bricks, but all the employee needs to see is the front of the house and the front door, right? So they only need to know how to get into the system. And so what our hope is to have one call, that's all. We want to make it as simple for the employee as possible. And that's, I think, pretty critical in these plans, because we can't have them calling, or having to call 4 different groups to be able to get an answer. So for any company that's starting out there, because there's a lot of them now, there's a ton of companies trying to create this, because we call it an unbundled, actively managed employer-built health plan, as opposed to the reverse, right? Like the bundled carrier-built health plan. They have to make it simple for the employee. One call, that's all. So in our plans, of course, we want them to first call the direct primary care if they have signed up for that program. That person, that doctor, should know them well enough to be able to hopefully help them. Now, if they can't and they need a specialist, they're directed to call our nurse navigators, and they have access to the very powerful, very expensive, really, databases that are able to direct them to the highest quality care for whatever their need might be. So it's really the DPC, and then if they can't handle it, it's the nurse navigator, where they're going to have the most interaction with the employee.
Makes sense. That's awesome. I mean, if you think about traditional health plans, there isn't a phone number that you want to call. You loathe trying to call that number, and you're going to be on hold and you're not going to get through. And the person who you're talking to is not going to be super educated on the thing you care about. And they're not sitting in front of a database showing high quality doctors and who's good for what. And
Right.
It's such a big deal. We're a tech company, so we get really excited and geek out about data. We've been playing around with that doctor quality and cost data a lot also. And it's just such a game changer. Like, if you have one of these navigators in your plan, and there's a few different providers and they're all great, but just like being able to look up who does the most shoulder surgeries near me, and like, what are their outcomes? And by the way, are they expensive or reasonably priced? Like, no patient in the country has access to that. It's such a big deal.
Exactly. And to your point, technology is huge too. I was reminded that just yesterday in a conversation, that a lot of these carriers, probably other companies, even TPA, some of them are using technology that's 10, 20 years old, right? And that just doesn't have the ability to act fast, to act accurately. And that's what I think is needed too. I mean, you're talking about a lot of data, claims, right? So a company like Milu is going to be really, I think, advantageous when we're trying to make this switch, because it's needed. We've got to have the technology that can handle this.
And it can never be the technology by itself, right? Like, healthcare is always human to human, like you're at your most vulnerable, you need help, you need somebody to talk to. So like the technology is never the answer, but it can help.
Right. No, absolutely. That's funny you mentioned that because I'm with a group of girls, just very humbled to be a part of it. One, we call ourselves the Six, and we're from all over the country. And again, iron sharpens iron, right? So we get together once a month, and we're going to be talking about different things. And our next podcast is actually on tech versus touch, right? Because
Awesome.
there's got to be a good equilibrium. Tech isn't necessary and required in this world, but there has to be the personable response available as well.
100%. Well, Liz, thank you very much. This has been awesome. It's been great
So fun
getting to know you and hearing your story.
Thank you so much, Sasha. It's been great fun. I really appreciate it.
Thanks for listening to Healthy Savings by Milu Health. If you would like more information about any of the topics you have heard today, we would love for you to get in contact with us. Find us on the web at miluhealth.com.